Good evening, everyone. My name is Tim Morris. I'm a volunteer for the American Lung Association, and welcome to the Community Connections session for this Wednesday evening. I'd like to start off with a little message to you from Tony Gwynn Jr. Well, while we're waiting for Tony, oh, here it is.
The American Lung Association has been saving lives by preventing lung disease and promoting lung health in our local communities for more than 100 years. And today, achieving health equity is at the core of everything we do. We believe everyone should have the same chance at healthy lungs and clean air, but we all know that too often those families with the most to lose get the least access to quality health care, the finest hospitals, and even clean air. This is one reason we've launched Community Connections, free, interactive conversation with San Diego healthcare professionals and medical experts on the health topics most affecting our communities. My fellow board member, Dr. Tim Morris of UCSD, likes to call them dinners with doctors. For more information about weekly topics and more, please visit lung.org/events. I hope to see you there.
Well, thanks, Tony. And welcome again to the Community Connections for this Wednesday. My name is Tim Morris. I am a volunteer for the Lung Association and the chair of what is called the Mission Committee. And the Mission Committee is a group of health experts and environmental experts from around the city and around the county who volunteer their time to help the Lung Association seek out the biggest healthcare problems, healthcare challenges and opportunities for our community and help guide them about where to direct their resources. One of our endeavors is the Community Connections series that you're seeing right now, where we're going to try to bring you up-to-date information that is timely to what our current healthcare needs are. Community Connections was made possible by the generous support from the Burr Heart and Lung Clinic at Sharp Grossmont Hospital, as well as the San Diego Foundation. We have a variety of different topics. We have some that we've already done, and those are available on YouTube. We talked a bit about cross-border medicine between San Diego and Tijuana in defeating COVID-19. Last week, we heard from the frontline responders, the 911 responders, and how they were doing with the COVID crisis. And today, we're going to be talking with Dr. Kaveh Bagheri from Sharp Hospital and the Burr Heart and Lung Clinic, and Dr. Mark Fuster, both of whom are Mark Fuster from the Veterans Administration Hospital in San Diego. And both of them are experts in the screening for lung cancer. And we thought that was a really timely topic because we know that during the pandemic, maybe we've let a lot of things go, and perhaps maybe to our detriment, we've let a lot of our healthcare issues go. And we thought it'd be really important to take that really vital topic, which is capable of saving lives, and make sure that we're up to date and to do the right thing for ourselves. I'll turn over the discussion to Dr. Bagheri, who will lead us off. Dr. Bagheri.
Good afternoon. Tim, is my screen on?
It is.
Perfect. Well, good afternoon, everybody. My name is Kaveh Bagheri, and I'm a pulmonologist. I have been practicing at Sharp Grossmont Hospital for the past 28 years. I actually first like to thank American Lung Association of San Diego for the hard work that they have been doing to provide education to the community. On many grounds, they have been fighting for the lung health when it comes to smoking cessation, and for our topic tonight, the lung cancer screening. I also want to acknowledge Dr. Morris has spent a lot of his time from his very busy practice to provide volunteer education to the community and also to many of the physicians in the community. So thank you, Dr. Morris. Lastly, I would like to thank Sharp Grossmont Hospital for sponsoring these the community connection programs, which I think it is very educational. So to get started, one of the biggest challenges that we do face is lung cancer in our community. And American Lung Association of San Diego has taken this mission to defeat lung cancer. When we talk about defeating lung cancer, it has multiple dimensions. One of them is, for example, what is the main risk factor, such as smoking, and how can we fight it? And that is, again, one of the missions of American Lung Association, to stop the young people from starting smoking, and for people who already are smokers to quit and go through smoking cessation. The other aspect of fighting the lung cancer is when the diagnosis is made, how to treat that. But tonight we're going to talk about how can we screen for lung cancer, especially during this pandemic. So first, what is screening? When we talk about a test, which is screening, is to identify a disease, such as in this case, cancer, in people who do not have any symptom. This is really important. If a patient comes to the office and they have lost 40 pounds and they're coughing up blood, doing tests is not screening anymore. At that point, we are trying to diagnose a disease. Screening is to get a population who does not have any symptom, and we run a test to make an early diagnosis of a disease. When we look at the history of screening, the first screening test which became available was in 1923, and Pap test or Pap smear was introduced at that time for early detection of cervical cancer. And by performing that screening test in asymptomatic patients, the mortality from cervical cancer was reduced by 50%. Now, there are a lot of screening tests that we are all familiar with. For example, performing mammogram for early detection of breast cancer, which was introduced in the 1960s. And we know that once you perform the mammogram on a specific population, you are able to make early diagnosis of breast cancer, and that has significantly changed the prognosis and the mortality from breast cancer. Similar thing with colonoscopy for detection of colorectal cancer, and also some blood tests, such as there is a PSA blood test, which may help with early detection of prostate cancer. But tonight we're going to focus on lung cancer. Is there any screening test that we can perform to help us make early diagnosis of lung cancer? When we look at common cancers and cancer death in the United States, you can see that the most common cancer in men is prostate cancer. The most common cancer in women is breast cancer. But the most common cancer death in both men and women is lung cancer. And that is why when we talk about lung cancer being a deadly disease, is for the reason that it is the most common cancer death in both sexes. Now, why is lung cancer so deadly? Because by the time that we make the diagnosis of the lung cancer, the disease is already in later stages. Patients present with chest pain, they're coughing up blood, they have already lost 40 pounds, they have severe bone pain because there is metastasis to their bone. So by then, the lung cancer is in its advanced stages. So the key is, how can we make a change? How can we screen and detect lung cancer earlier? So there has been many screening attempts, such as performing simple chest X-ray 3 times a year in smokers to see if that can help us with earlier diagnosis, and that was not successful. In 2002, the National Cancer Institute launched the National Lung Cancer Screening Trial, which compared the CAT scan with X-rays to see, does it make a difference? Can it change the mortality? 8 years later, in 2010, they actually stopped that trial because the group which was having CAT scan performed as the screening test had a significant reduction in their mortality. So we need to make an earlier diagnosis of lung cancer by performing screening. And we know that if we diagnose lung cancer in its earliest stages, we may even lead to curing the disease. So now the big question is, who should be screened? So because you cannot, when we talk about lung cancer screening and performing CAT scans, you cannot pick the whole population to do this test. We need to identify a population at risk, which can have the benefit and a reduction in mortality. So at this stage, I'm going to pass the rest of the slides to Dr. Fuster. Let me stop sharing, and you can now proceed taking over the presentation.
Great. Just going to share my screen now. Let's see if I can get that. There we go. All right. Let's see if you can. Sharing now. Can you let me go back a slide or so. One moment. And there we go. Can everybody see that? You hear me okay?
Yep.
Great. All right. Well, thank you, Dr. Bagheri. Just chime in or hit a chat if any concerns with seeing or hearing me all right. But thank you so much for this opportunity. I'm Mark Fuster from the VA and UCSD faculty member, and we're Dr. Bagheri gave a really nice introduction. I would echo his thanks to the Lung Association, to Tim Morris. Thank you, Tony Gwynn. Normally I'd be giving this talk today with my colleague and friend Phil Montgrain, who couldn't make it today, but I'll speak in his place as well and sort of share the concepts and talk as we would together. We're both very passionate in the fight against lung cancer in our center, and really, again, give thanks for this opportunity to share with the community the importances of lung cancer screening, put it in a little bit of perspective with current issues with COVID challenges and other challenges that I'd like to bring up that are very important, independent of COVID, which is a tough enough time with the pandemic that we're in, and put it all in perspective. And so kind of with that introduction, kind of take off where I very much appreciate where Dr. Bagheri introduced the topic extremely well, and was talking about a unique population that is the lung cancer screening eligible population. And again, I'll back up a little like was done earlier and talk about the global health burden of lung cancer as it is in 2021. It's the leading cause of cancer death. I'll echo that again in the US and the world. And in terms of US numbers and rates, our 5-year survival is still dauntingly low at just over 20%. That's a 5-year survival from lung cancer. The acronym there, NSCLC, before I talk about that graph, is non-small cell lung cancer, which makes up the bulk of lung cancer, but there's also small cell lung cancer. And both of those types of lung cancer are far and away, the highest risk is tobacco, which accounts for about 80% of that risk. So it's obviously the one gorilla in the room is working on tobacco cessation. We'll get to that because that goes hand in hand with lung cancer screening. But the kind of obvious calling for lung cancer screening is really shown nicely in this graph here from the NCI, from the SEER database. And it really shows an updated graph of what the incidence rates of these cancers are in blue, which are lung cancers on the left there. But the other ones shown there, some very serious cancers like colorectal, prostate, and breast cancer. And Dr. Bagheri touched on breast cancer, and death rates, which the red bars are really what is the dominant concern here, is that for one, in the US, lung cancer makes up more than the sum of the red bars from these three cancers already in terms of a sum. And the other part is the death to incidence ratio, just with every year new cases and how many deaths we get. Over half of the deaths to incidence ratio compared to the others that have a much lower percentage is probably on account of two things. And one of these is the fact that there are screening programs that have been in place for a while for these other sites of cancer. But the other one is just the metastatic aggression of lung cancer that even when caught early can be very metastatically aggressive and spread very quickly and cause death through widespread metastasis or even local effects on the lung and morbidity that become very severe. So with that kind of intro, I want to dig a little bit deeper into the numbers that are sort of behind the study that Dr. Bagheri introduced. Is, what population are we talking about? Who's at risk? And what was the big study, at least in the United States, and there were a couple throughout the world, that we've gotten data that taught us that screening is important and does save lives. And so the screen itself was, at least in the US, was this National Lung Screening Trial, or NLST. And there was over 50,000 patients where they had screened over a few years using a modality such as a low-dose CT scan versus a chest X-ray. And Dr. Bagheri introduced the chest X-ray. It isn't quite good enough. And the at-risk population that was looked at, for various reasons, they integrated the most important concerns being smoking, a no-brainer in the room, which is a certain amount of exposure. So 30 pack years cut off, which is equivalent of a pack a day for 30 years or 2 packs a day for 15 years, a certain level that puts you up with enough smoking and having smoked within the last 15 years. With that amount of smoking and with this age range of 50s to 70s, where just any kind of radiation for detecting cancer would put you less at risk of getting cancer at this age range versus putting X-rays onto somebody that's very young. And because we see the disease at this age range more, again, that combination is what was used in the study. And what they did was this low-dose CAT scan. So it's a CT scan normally has quite a bit of radiation compared to a plain chest X-ray, but by giving a lower dose, with a low-dose CT scan being about the equivalent of maybe 10 chest X-rays as opposed to about 80 chest X-rays, which is a normal a full-dose CT scan. These low-dose ones did not contribute to cancer risk, and done as a yearly test over 3 years, randomizing people to a chest X-ray, which is shown here, shows the heart, the lungs there, and the bones and the ribs, and pretty low sensitivity for being able to pick up nodules. Here showing a slice through a low-dose CAT scan, which is a quick spin of a low amount of radiation over the body to actually essentially give you a lot more definition than a chest X-ray, showing the heart, showing the great vessels coming off in the airways. And here are the lungs in black with little dots being blood vessels and structures in the lung that are normal. And this nodule standing out like a sore thumb here that very often wouldn't be seen in a chest X-ray. And so that's where, done yearly ×3, there was a significant effect on reducing mortality. That's the data behind it in a very big, a massive trial. They've had similar experiences in the Netherlands and other places in the world. And we've come to learn that this significant reduction in mortality impacts a lot of people. In fact, the number needed to screen to save one life in lung cancer is about 320 screens. And just to put it in perspective, while that number seems like a lot of screens, in breast cancer, the equivalent time, it was about 900 screens to save one life. So it's picking up a lot. We'll talk a little bit more now about the other side, which is at what a cost. And so digging in a little deeper, you can make a balance sheet for 1,000 screens, for example, and say among 1,000 people, how often do I save lives? How often do I get a complication? And these are some of the comments that might come from patients being screened from kind of a balance sheet of how often you're having a success or an impact on mortality versus you're having a complication or a concern from the study that's not giving you the information or leading to a complication. And these are some of the typical numbers or comments. So you are saving about 3 or 4 lives per 1,000 screenings. I might be one of the saves. And when you take tens or hundreds of thousands of people, you're talking about a lot of lives saved over and above a chest X-ray technique. But then at what a cost? So many screens will have a false positive result. And what we mean is that a nodule will be picked up, something like a granuloma, a very small nodule that is often something that has to be part of the shared decision-making to understand that that could very well come up in 20, 30, 40% of the time. That is very common if you really high definition screen a chest. And those granulomas are just common little nodules you see in the population due to just ganging up of some inflammatory cells around anything that causes lung inflammation, from mild infections to funguses to other things in the environment. And they're very common. If you push this hard enough and you start doing procedures on too many people, rather than simply repeating the scan and seeing that those nodules either go away with a yearly repeat or they're stable, that's how you wash out most of these in the screening process. There might be a couple of screens that actually get a complication from that false alarm turning into an invasive procedure, causes, for example, let's say a biopsy for the lung, a collapse of the lung that needs a chest tube or bleeding or something like that. And so those are concerns that are part of the shared decision-making process with, in good hands and good centers, this not being as much of a problem, this follow-up being very close and tight, and saving a life as being one of the many that could be you. Or this attitude, I just don't know, I don't care to know, leave me alone. Not uncommon, I don't want to deal with any of this. And so we'll dig a little deeper into some of that. But if you are a center that does this, and it's a comprehensive lung cancer screening program that's in the center, you have to be ready to deal with it. And so some of our in centers that do screenings, I'm sure Dr. Bagheri can tell you, and others in the community that run screening programs, you have to have a pool that's screened. You have to have educational materials, coordinators to track patients, a cessation program for tobacco. And that can be as powerful, if not more, in saving lives than the screening program itself. Just having that moment of being able to share the importance of quitting smoking as you're looking into a screen, whether you do it or not. Radiology reporting, there's kind of a lung rad system, which is just the way the radiologist says, I'm worried or mildly worried, more worried, or severely worried. There's a scale of 1 to 4 of the size of the lesion, the concern of the lesion, whatever is caught on a positive scan, and would prompt repeated scans either earlier or actually acting and getting a diagnosis of lung cancer through the appropriate downstream services. And so we have to have a lot of specialty capacity, the right scanning technology, the right radiology, the whole pulmonary system, our pulmonary physicians, primary care that make referrals, oncologists, pathologists, cardiothoracic surgeons, lots of specialties of radiology, interventional pulmonary. These are all teams that we work with together in a large center that can handle, if you have a screen, you got to be able to know what to do with it and deal with it right. And very, very importantly, equally importantly, if not more, is a tracking system so that we have a dashboard for all enrolled patients and someone is watching, coordinator, a team to make sure that followed up scans are followed up and we can monitor outcomes. So those are some really important elements in any screening program. And where our US Preventive Services Task Force has taken us, and this is a task force that really looks at screening and the importance of keeping up with screening in various different methods, from cervical cancer to breast cancer screening to lung cancer screening to any kind of screening. Lung cancer screening has actually advanced now to get the recommendation of a B recommendation. And that's very common in screening systems because a B means you have some of those intricacies, those needed follow-ups. It's not an instant answer, yes or no. And but it's a strong enough recommendation and saves enough lives at a different threshold now. So we're at a threshold of 50 to 80 years of age and 20 pack year threshold. So the pack years have come down some. We take a little wider age range now for who benefits, and having smoked within the past 15 years. And being in a situation where there's not a serious health problem such as advanced cancer that's already known or something else that limits life expectancy where this is going to make a difference. It's quite well known that there's no role for screening in non-smokers. And I'll talk about some additional individual risks that are challenges in the system. So that's kind of where recommendations are at and putting it in perspective. Let's talk about that a little bit more here. So here's a situation where you have a mass screening program, and this is where tobacco is the risk factor, and cessation has been discussed, and everything's very tobacco centered in terms of risk. And what we're looking at now is the situation of an individual that now has certain risks, such as a family history of lung cancer or emphysema, COPD, or has cancer. And these individual risks, or asbestos exposure, or any number of risks that are individually could contribute to lung cancer, but really just based on our tobacco exposure of how many pack years and when they quit, have a certain risk that really is the one that makes us screen with a low dose CT scan. And just to explain one more time what pack years means is our threshold is now 20 pack years. And that means there's a number of different ways you can get to 20 pack years or 30 pack years. Let's take 30 pack years here. Again, and just to emphasize, it's a certain exposure to an amount of tobacco. So it's a pack a day for 30 years, or 2 packs a day for 15 years, or 20 pack years might be 2 packs a day for 10 years. So it's that multiplication that we do. And it just means there's a certain amount of exposure that a person's had to tobacco, and having quit within the last 15 years keeps them at risk to fall into this mass screening program. And let's just illustrate here, that mass screening program probably had lots of people that have a 6-year risk of lung cancer of around 1%. This individual, however, a 48-year-old African-American male that has the thresholds needed for our low-dose CT scan and a number of other risk factors, if you put him in one of our calculators that many of our sophisticated epidemiologists used during the design of the mass screening program, you can actually come up with a much higher risk of lung cancer in that individual. And yet by age, this individual does not qualify. So there's a challenge already. I can move over to somebody different who does qualify, who does not have a family history of lung cancer, maybe has a different educational level, is a white male who will get into disparities and race and ethnicity in a moment, but there are differences in risk there. And if you just look at the amount this person smoked and fits into the screening eligibility, this one does and this one doesn't, and yet the calculator risk in this individual is only 0.5%. Now, 1% is already high, I'll warn you, that's even 3% is very high, 1% by risk calculators is moderately high, and that's where most people fall with a certain amount of variation. But these variations can really be important things to think about in individual risks. And I'll get a little bit in a slide or two in a moment here, just to get into it a little more, is there are some important thoughts to talk about in terms of race and ethnicity and other disparities. And disparities just means basically that there is a difference in either access or the outcome of an intended healthcare system technology that has made that ends up being different between one individual versus another individual. And so there were not equally given the same outcome or the same chance with the same technology. And we'll get to that in a moment, but we have a lot of disparities beyond race and ethnicity, but that's just one of them. And it turns out that the overall incidence of lung cancer in California is, and this is per 100,000 per year, 54 among Blacks and 48 among whites. Nationally, this varies in different states. Hispanics in some places and nationally might even have less than white. Native Americans have higher incidence. There's many reasons for this. These aren't just biologic reasons. These are reasons that many times have to do with inequities in the system and access and other things. But just for the numbers for what they are, they lead to differences in risk when these calculators are used. And actually, it means that we have to think about inclusion and how we're doing our screening, that we capture everybody and give everybody a fair chance, and think about thresholds beyond a mass screening program. So these are just some thoughts to sort of throw in there. And in addition, just beyond this, I'll get to disparities a little bit more because it's a very important topic in medicine, but also in screening. But just research advances in general to make our low dose scans better or more selective for individuals so that there's a higher chance they do pick up lung cancer and less of a chance that you're following or doing too much to somebody with a positive scan to cause harm and rule out the ones that don't have lung cancer. And what are those advances? There are things like biomarkers that are being done, even blood tests that take a number of markers that drive cancer in the blood that can be detected. There are antibody tests. These are being designed right now to more enrich what a low dose scan tells you when you see a nodule. Is it someone you need to act on, or a nodule that can just simply be followed with serial scans if it's kind of intermediate risk? Sometimes these are called classifiers. You might come across them that way. And basically, the ongoing work being done right now in a lot of research, but it's coming very close right now, is validating in different populations what populations this will help and what populations this may not. These could be segments of it might be a country, it might be the US versus China versus Sweden. Many different places are running these and testing these to refine or help our low dose CT scan do a better job in selecting who do I want to follow serially and I'm not worried about versus who would I really want to go after for lung cancer because there's some risk involved. So back to some of these challenges, I just want to kind of put them back into perspective, the issue of disparities. And these are just some points I'm just want to raise for thought. And there are things we come across all the time right now. It's not just the issue of race and ethnicity that I think I've explained reasonably well with just an example there earlier, but also access to care that impacts different ethnic and racial groups, socioeconomic status, insurance issues, access in the general population, specific populations that have higher biological risk. So HIV, having had different exposures, having different diseases. HIV is actually well known to have a higher incidence of lung cancer, and presentation of lung cancer for whatever stage has a higher mortality. There's immunologic problems with T cells in HIV, and so that's probably the reason, but we don't know all the reasons. But again, this population, we need to give it its due attention in terms of screening, and not just put it as a higher risk, but also make sure that they are not lost to access, or that we can offer it as a tool to make a cure at an earlier stage in that population as well. There's others, and there's a number of social factors, and maybe because of many of these, but also despite our efforts here in California, there's just a factoid there that 6.4% of those eligible, this is currently for screening, are actually screened. And that's actually a mean among many states in the US that actually ranges anywhere from as low as 2 or 3% all the way up to not 50%, as you would think and hope, but it's actually only in the 10, 12% range. And that's just because of a number of these factors: utilization, awareness, access. All of these are issues that we, in our early experience in lung cancer screening, are hopefully boosting these numbers much further up in the future, so that more of the eligible will actually be screened. Other disparities are in insurance coverage. Luckily, Covered California allows screening for under insurance coverage. Medi-Cal and Medicare do allow it, and it's not the case in several states. There's maybe 10 or 12 states where it's either not covered or not even available in most centers as a tool. And so this is really something that nationally, globally is very important in terms of an access issue. Bringing up some other disparities, just kind of as key points here, and thinking about, and I'll get to an example. I think a good example that illustrates many of these is anything from education to income to employment issues to health literacy. These are all barriers potentially that can make some segments of the population, and often very large segments of the population, not have access. And even if there is access, it's often at our end, in our healthcare center, our job to make the awareness or bring it into the calculation, the discussion with the patient in any setting. So here's an example. Actually, this is one that we used the other day recently. One of our fellows, Brenda Desai, she's one of our super pulmonary fellows, who was educating a number of medical residents with a case-based example. And she's really a champion in health and disparities and inequities and in healthcare. And she took a little passion, which I mentored her in a lung cancer screening project. And so we went ahead and did some interviewing and did also some education of medical residents in a teaching session. And we presented this common scenario that many of our resident physicians would come across. Mrs. D, who's a 57-year-old smoker, female, 25-pack-year smoking history. So she kind of, she fits the age and the exposure, and she's a smoker now. And she brings up lung cancer screening as a query. Again, all these little red flags that make challenges. At the end of the clinic visit, might be a little rushed. She just came to the clinic after a long time for the first time. She's got questions about screening. And in the face of that all, there's this background of the fact that she's a primary caregiver for her mother and 2 grandchildren. She supports people on one side of the border and the other side of the border. Her father passed away recently. She's had no primary care doc since that time. She's caring for her family, and she picks up the odd shift at the restaurant because she lost her main job. There's transportation issues. The first language is Spanish, but she prefers not to use the interpreter. Lots of little quirks that make the ability to have a discussion, and especially a big one here, not ready to quit, but kind of contemplating tobacco cessation, can be challenging from a number of possible barriers here. And this is the kind of question we would pose, is when preparing to discuss lung cancer screening, what challenges do you predict she may encounter? And we could throw in there more, what if there's COVID? What if she lost her current pickup shift job at the restaurant from COVID? And so you can keep throwing in the wrenches and the challenges, not only in the ones that exist outside a COVID environment, but what the heck, throw in COVID. And this is nationally, globally, a real issue. Too, not just for lung cancer screening, but lung cancer itself. COVID and lung cancer has been a very serious issue. Lung cancer has been found to present in the COVID era. It's been well studied. There's lots of papers from Spain, from the UK, from the US at a later stage with higher mortality, a lot less lung cancer screening, because when this pandemic hit, a lot of people making decisions about, I don't want to be exposed pre-vaccine, even post-vaccines, who cares about nodule tracking, even if you do pick up a nodule, what is that all about? It's not as important as these, pandemic atomic bomb risks and my health and the safety of my family, and all that can be pushed aside for now. How is this a time to screen? We had a little discussion of this, I think we had a chance, Dr. Montgrain and I, on a previous session to just talk about chronic lung disease, which lung cancer is one of them. It is one of the big elephants in the room, and just how COVID derails care and reduces the opportunities among all those other challenges that we brought up to lung cancer screening in this era. And we also talked about not only personnel and resource issues, but persistence, and how in COVID, I think we've come to learn that, even when things were maybe even rougher than they are at this moment in time, as rough as they are, Delta variant and things going on, that there's telehealth. There were ways to get around this. It's important for primary care, it's important for specialists to stay on their patients about the importance of a disease that marches on and keeps going and kills and can be going on in the background just as aggressively as it ever does. It did take a holiday from COVID in the past. So really just wanted to hit that point home and kind of take that last example and just throw in yet one more twist to show how things can get tricky and the barriers can get more challenging. Just to kind of end on a few more limitations that are important and that we encounter in trying to make sure that we're keeping up with screening, and everything that's involved in screening is, for example, shared decision making. These tools are not designed to meet all those barriers a lot of the time, and even when they are designed well, we have pamphlets and flyers, and primary cares use them, and we post them, and we post updates for primary care in our center. Even then, the encounter with patient is often like with Mrs. D. It's that kind of, you have a moment to get to it. I really think screening's for you, and you might get a head nod. Okay, let's do it, and fine. But there really wasn't a shared decision-making process. And what if something happens down the line? More questions come up. What is it for me as an individual? These things are in a very well-designed program, something that can be a little deeper with each patient and can have a little more time or a way to sort of bring it up, even if it takes a separate bit of discussion or session or something else that can be done to help bolster the importance of it and have a shared decision-making process. That's the ideal. There's implicit biases based on sex, race, ethnicity, perception of providers, the patient or the provider. This can negatively affect communication and patient-provider interactions. So we have to be sensitive to those types of things. And really, in any program that even has the downstream tools to deal with in a big center that deal with the ramifications of screening, we can get the benefits, but also do we have the awareness, the utilization, the physician training to bring this and bring it to the table each time? And again, that might be something that would advance those numbers of getting more screened among the eligible population. And really, I just wanted to end it here just with an advocacy slide. I actually also, this was one that Brenda brought up in what we did together there, is really just having the opportunity to work with resources from a number of caring organizations, not only the American Lung Association, but many organizations that have a voice for advocacy. And it will take time, the grassroots, the sort of working our way to help the system by telling your congressman or working through these foundations takes a lot of time, but the investment it's never too late, and the investment can be now for all of us to kind of work with organizations such as these to make more of a voice for screening, make it more available, make our awareness, our understanding of the challenges and updates, so you get the most bang for your buck here, and make an impact on our population, because it does save lives. So I think I'll actually stop it there and hope that provided a lot of helpful interest and food for thought. And I thank you for this.
Well, thank you very much, Dr. Fuster, Dr. Bagheri. Now we're going to invite the panelists who are the other members of the mission committee. And we have Dr. Angela Wong, who's an expert in outpatient adult medicine. We have Dr. Laura Crotty-Alexander, who is the section chief of the pulmonary section in the VA Medical Center and also UCSD faculty member. We have Dr. Praveen Alkathoda, who is another expert in inpatient and outpatient medicine, who has a special interest in airway diseases. And then Dr. Mike Welsh, who is a pediatric allergist, also interested in airway diseases, but at the other end of the spectrum in kids. So welcome, panelists. And we'd like to have a little bit of a discussion about what we just heard. And I'll start off by asking, what is the impact of the latest little tools and technologies for diagnosis? You see, billboards that say, "Oh, we've got robotics to use for bronchoscopy for diagnosis, and we can guide our scopes with CT scans, et cetera." All of the things that you talked about were back in the day before those things were there. So does that affect any of your decisions about who should get screened and what you should do about it when you find something on screening?
Great question. I'm happy to answer that too. Dr. Bagheri, do you have any insight you want to bring into that? Sure.
Well, since I'm one of the two people in town who does the robotic assisted bronchoscopy, I can comment on that. I think from the screening standpoint, we still basically follow everything that we presented. The question is, when we do find a nodule, depending on the location, we need to find out if this abnormality, this nodule, this shadow, is this malignant? And if it is cancerous, what is the best approach? So we know that in certain cases, depending on the location, it may be challenging. I think our technology has improved significantly. Our colleague interventional radiologists are superb in obtaining biopsies when these shadows are more peripheral, but there are certain locations that it is very challenging. And the new technologies, as Dr. Morris mentioned, such as robotic assisted bronchoscopy, is just another tool which can assist us in early diagnosis. So we do the screening CT, we see a nodule, then we use our technology available at this time to make the diagnosis. Thank you. Go ahead, Dr. Foss.
Yeah, and I'll echo what you actually mentioned about downstream services. So we've really advanced a lot in terms of being able to pick up smaller and smaller, but more worrisome nodules. And sometimes one of these entities, we showed a lot of solid nodules, even some of the pictures, but there's actually some of these smaller nodules that are little ground glass nodules with a little solid component. They're basically very worrisome for early lung cancers, and that's picking it up quite early in some of them. And so with navigation technology, with technology that can bring the scope through interventional pulmonary further, not just lung biopsies on bigger nodules. And again, location's very important, as Dr. Bagheri brought up. We have technologies that can reach further, look further with greater safety, although you're also balancing that with some complication risk. And sometimes we come up short. And we also have a certain amount of judgment that has to be made of where you're going to be aggressive on a nodule that looks ugly, even if it's not the biggest nodule. And it looks in the remember, this is a screened population, so they're already at high risk. And you can go, instead of a lot of diagnostic technologies, there's going to be a chunk of these people that can go right to surgery, just given the risk. And that's not done blindly, that's done in a tumor board and with a lot of thought from everybody involved. You can use a risk calculator on the individual that you did pick up. It's a different risk calculator because now you have a nodule and it's not a calculator for screening. And in that kind of a situation, you can say how much, 80% risk, heavy smoker, spiculated, ugly, even if it's a 1.5 centimeter nodule, that might go to, that situation might go to surgery right away.
Yes, I'm wondering about, Dr. Fuster, you had quoted a number about how many scans you would need to do to save a life. But of course, that was back in the, more than 15 years ago, when our tools for both sorting out which which spots on a CAT scan are cancer and which ones aren't. And also our ability to treat those cancers has really changed. And I'm wondering if you could guess, or I guess guesstimate, is it more, are scans more effective? Will we save more life with scans now that the science has caught up to the CAT scan technology?
My guess is yes. And it's just, I think it's because it's gotten that much better and we can detect that many more. My guess is yes. The problem is some of the research and refinement can go further. And so selecting scans that you can simply watch and not act on, and even before the fact, selecting, correctly, like I said, a scan that's going to make a difference is one that you have additional information sometimes to make that decision on. Does come in the future with, it's going to get even better with biomarkers, with classifiers to be integrated with the scanning. Dr. Bagheri, do you have thoughts on that?
So absolutely, I agree with you 100%. But one thing which is very interesting, if you look at the guidelines, initially, the age which was picked up was 55 to 75. And then they changed that from 50 to 80. The number of cigarettes that was consumed, they changed it from 30 pack year to 20 pack year. The reason is our treatment has improved so much that now it is much easier to deal with someone who may be 79 years old, while previously we would have turned them down, for example, for surgery. If you look at the thoracic surgery, the technology has improved significantly to the point that at most institutions in San Diego, a lobectomy can be done and the patients will be home in 2 days. A lot of these peripheral lesions, even in high-risk patients, a wedge resection carries the same risk as if we do the biopsy by a CAT scan. So therefore, we are now doing the screening on a much larger population because there is a lot more we can do. And as Dr. Morris also brought it up, I think the number needed to screen to save lives has improved because our complication rate has decreased. When we looked at the benefit, we saved a lot of lives, but then we also had complications. There were a lot of patients who may have had CT, CAT scan biopsy performed with complication, and now all those technologies have improved. So I think the numbers are going to continue to improve.
And we've come to learn the other end. You took the high end, Dr. Bagheri, of pushing on 80 and being able to do something. The reason from 55 down to 50 is a whole another group that it's going to bring in a lot more people screened, but we've learned there was a lot of fear that biologic risk from radiation could cause cancer early in the course. And we've seen that we haven't been doing this. That risk increases kind of asymptotically when you're sort of going from 30s, 40s and up to 50s, it starts to plateau a lot. And past 50, it's safer. It's just there was a lot of fear. 50 to 55 was a gray zone. It now looks safe to bring low dose scans down to 50.
And I just want to add one more quick point, which I think is important. I have seen such a difference in the success in smoking cessation after we sit down with our patients, showing them their CAT scan, showing them a shadow in the lungs, which is concerning, and letting them know that smoking is a risk, which can place them at a much higher risk of a cancer. And when they see that nodule, when they go through the biopsy, it really will encourage them to quit smoking. So just the fact that they go through the screening process will improve our chance of smoking cessation.
Other questions?
Yeah, none of the other panel. Oh, go ahead, Dr. Wong.
It was just a question, Mark, to expand on the point of radiation exposure, because I have a lot of times women asking me, especially, so you're to screen me for lung cancer, but am I going to get breast cancer from, the radiation exposure? Can you comment on that?
That's a great question. And the biologic curve, there's a lot of published data on biologic curves for full dose CT scans and the risks when we were coming into screening, and that sort of risk that suddenly becomes much less with age, that I can tell you for lung cancer, I honestly cannot tell you for breast cancer. We have not seen that as an issue in terms of inducing the risk of inducing breast cancer that's come out of any of this. A lot of that data, I will say, so far I know of nothing that when all this has to be adjudicated and it gets a US Preventive Task Force Services grade, anything like that should be such a sore thing that it would be a C or a D very quickly. And that just hasn't come out. I'll be honest though, I don't know how that biologic curve looks for breast cancer for a full dose CT, but these are low dose CTs. So it's actually, instead of the equivalent of 80 chest x-rays, which is a full dose, which is about 8 millisievert, these are 1 or less millisievert, maybe 10 chest x-rays or less. And so is that worth the once a year thing? And, we do a lot of chest x-rays on people. And so that's where the sort of, but it's concentrated, it's given differently, is there a breast cancer risk? I think it's an excellent question. It hasn't filtered out to be a concern that I've seen. But Dr. Bagheri, any concerns on your end?
No, I will just echo what you said. We know that the amount of radiation with a low dose CT is 80% less than a CT of the chest without contrast. So that number is very encouraging. But again, if we diagnose someone, if we put a 50-year-old through screening and they continue to smoke, that means for the next 30 years, we're going to be doing this screening. But again, if they quit smoking or if they have already quit smoking, that will definitely reduce the number of the years screening is needed.
And you bring up a good point in perspective. So back to for Angela, it could be that you're dealing with a patient that about half the time you're really worried about lung cancer risk, and the fact that the lung cancer that can take them, if something is there or looks suspicious on a scan, was that worth it? Compared to this number that I'm trying to search for that is not, not leading to a problem that I know of from breast cancer, where that risk would be very, very, very low compared to the risk of actually picking up lung cancer in a high risk population, has to be put into perspective with any shared decision making with a patient that, boy, I'm a lot more worried you get a chance of getting lung cancer and dying of lung cancer than that this very small, it was weighted as being safe in a wide population with a low dose scan that you ever get a breast cancer in that setting. But it's a very good question. It's very concerning for radiation of any sort.
You had mentioned, both of you had mentioned how long the screening should go on for. And in the trial that you discussed, screening was every year for 3 years. And then I suppose, at least in the trial, you considered somebody clean if they went for 3 years and you wouldn't test them again. Is that currently still thinking? If somebody is 55 and goes 3 years, are they good till they're 80?
So I could try to answer that. Just the issue was that the very good question about, how long do I get screened? Because you're right, that data came out, it was 3 years. And it's one of those effects that the early data, the relative risk came out so early that we could say, and that's how it was designed. So it was a 3-year choice. It was by, upfront, but the data came out immediately. And the point is that the threshold that was used was a within 15-year threshold. So to really feel that you complete that safety, you have to be out of the 15-year window. And when it's found to be safe and there's a mortality risk at the 3 years to teach you that there's a mortality effect, then you still are dealing with a population that was chosen to be screened over a 3-year period that is within 15 years. So completing that 15 years is what has been recommended since. And so basically, if you're 7 years, keep screening yearly for 8 more years, and that's when you would be done. But that's the rationale, because it was applied to a 15-year window population, but with that dose of 30-pack years, et cetera. But any other comments on that? Feel free.
So I think, exactly as you said, the 15 years is the cutoff. This is 15 years since cessation of smoking, or if they reach age of 80. So they may still continue to smoke, but once they reach to age 80, the screening stops. Now, it may be different if in our CAT scan we have seen a shadow, a nodule, which is concerning. We will continue to follow that past age 80. But as far as the screening is concerned, today, recommendation for cutoff age is 15 years since cessation of smoking, or when we hit 80.
I have another question, and I think this may have to do with what you would say about the sort of fatalistic comments, Dr. Fuster, that you had quoted one of your patients saying, or saying, "Look, I don't want to hear about bad news. I'm doing just fine. I'm feeling great. What good could possibly come of this just by you showing me this bad news?" So if somebody said that to you, what would you answer them in 2021 about what good could possibly come from finding out bad news?
I can answer it, sure, and then maybe Dr. Bagheri, what you tell them. But I think it is always it's always a tough question to approach, that one, Tim, because what you run into is you're like, okay, so this is going to be the one that gets, I talked them into it, and now comes some complication. Our brains always run with this, like what. But you have to push that aside, and you have to say, this is another person that's asking a very good question, is screening for me, and you have to, this is the point about, it's probably your best candidate for shared decision making, that you have to give them the other quotes that are in there. So it's good to sort of, and that's why I put those specific quotes, is what's the good? And yes, it's it sometimes can be best explained that it's a 3 or 4 lives saved out of 1,000 people, and it may be better. Our technology's gotten better. If you take 1,000 and go to real population and how bad lung cancer is and how aggressive it is, you multiply that by 10,000 to 100,000. That's a lot of people with a very, very serious disease for which there's an opportunity to pick up. And then you have to couch a lot of points about the fact that you might get a little nodule, but nodules are common. You can't lose sleep over it. That's going to be the most common thing we might see, or nothing. And then there's this small chance that we look and find something that's dangerous and act on it, save your life. And then the last quote is important to give to that same person for shared decision making, is that a couple of times, but we're a great center, we're going to do this with care, it's individualized, here's what we're going to be doing to do your screening plan. And if we find something, you can give a couple of scenarios, but that 2 or less per 1,000, it's probably less with better technology, is a very, I would counsel that person to say, please focus on that, because it's getting better and better. And it's a very low number to begin with in the screening trial, for which the benefit far exceeded the risks. So you have to kind of go through the shared decision making, and shared means they're going to ask questions on each of these as you're going. But Dr. Bagheri, how would you?
I agree with you. I think number one, I have made it my practice not to lecture my patients. Number one, I think patients are in charge, and I let them know it's their health and they are in charge. But I will tell them what we recommend as healthcare provider. What is the best medical management? If I have a patient who tells me that they have no intention to quit smoking, they want to still continue to smoke 2 packs a day, and even if I find a cancer, they're not going to do anything about it, then you wonder, why should you even do a screening with them? Unless if you think that they may change their mind if there is something found. So I think our job as healthcare provider is to provide the data to them, let them know what is the best medical approach, but the final decision comes to the patient. Sometimes we get frustrated with our patients because they're not doing what we recommend, but I think we just need to go over that over and over and make sure that they have the knowledge that we have provided them, and then the choice is theirs.
Great. I think we have time for
just found patients to be very approachable. Yeah.
Can I just ask a philosophical question then? In general, do either of you feel like, do you think that's a reasonable reason to get a reason to get a pulmonary consult is like if a primary care physician says, okay, you match the criteria for doing low dose screening, but I want you to go talk to a lung specialist to have this discussion. Do you think that's appropriate, or is this something that should stay in primary care? I'm just asking it to see what.
So we've made,
go
ahead. Yeah, no, we've had the consult, we've just had the consult come out. We had the automatic consult for screens in the past so that primary cares were educated on all the downstream processes. Yeah. And now we've streamlined it because it got so heavy. It's just much easier once you've educated people for a while, they can do the shared decision. And when we get a level 4 and arguments can be made for level 3, that's a lung RADS reading, we actually have it in that language to order the pulm consult and see us. But we do leave, Angela, anybody and can ask for a pulm consult. We love them. We'll educate them even pre-screening. And if they don't fit the screening criteria, it's still a grounds for a phone consult for the individual risks that we're talking about. So that's how we handle it.
Well, everybody, unfortunately, our time is up. This was a fascinating conversation. I think we could go on for another hour, actually, but let me just end by thanking Dr. Bagheri and Dr. Fuster for a fascinating talk, and thank you to our panelists for adding to our discussion. Next week, we'll at the same time, we're going to have another Wednesday session, and this time we're going to be speaking again with Captain Amalari from the San Diego Fire and Rescue, who is going to be speaking with us a bit about the health effects of the brush fires, which are certainly at risk for. So thank you, everybody. This was a great session. It is available on YouTube, as are all of them. Have a good night.
Thank you.
Thanks, Dr. Bagheri. Thanks, everybody.
Thank you, Mark.
Thanks, Tim.